Good evening, everyone. So, lecture number 4 in the structural foot and ankle review course. We'll have today the ankle arthritis, the ankle instability, the heel pain, and Hallux Valgus. A nice and a very practical lecture. So, all of you, when you practicing foot and ankle or having a foot and ankle placement or rotation, you will be facing these problems very, very commonly. Again, my name is Mohamed Hashem, and I'm a foot and ankle consultant in Northwest London, Wixon Park Hospital. And this is where I come from, and this is the YouTube channels where all the lectures and education activities will be there. Do subscribe and follow them, and you will be updated with every new educational event or activity which will be on the tube. It's my YouTube channel. I'll also be my official YouTube channel. Perfect. So starting with the first one today is ankle arthritis. And ankle arthritis is really small, tricky biomechanical points which I need you to understand. As any form of arthritis, the patient will be coming to you complaining of pain, limited range of motion, some impingement, especially on dorsiflexion. Very common complaint. He comes to say to you that I find difficulty going up and down stairs. It's very, very difficult to me to climb a hill or go up hills. Very, very difficult. Maybe a history of pre-trauma or ligamentous injury or recurrent sprain. The commonest form of ankle arthritis, as expected, will be a post-traumatic ankle arthritis. And that's why ankle fracture fixation is very, very important, need to be done always by a senior surgeon. And you need to restore the ankle perfectly, and we'll understand now why. When you look at the patient, you found that the patient walking always with a stiff ankle gait. He couldn't allow the ankle dorsi or plantar flex. So we normally expect dorsiflexion to have a heel strike at the start of the gait, then plantar flexion to get the foot flat on the ground, then more plantar flexion when you're toeing off in the gait. So the main three rockers of the gait: heel rocker, when you do a heel strike, at this moment your ankle will be in dorsiflexion, then a flat foot when you're doing the ankle rocker, then a toe off when you're doing a toe rocker or forefoot rocker. So with ankle arthritis, because this movement is very stiff, the patient cannot dorsi or plantar flex. He will be losing at least the first and third rocker. So he walk with just a stiff ankle gait. You can obviously see a deformity. Commonly see it's a varus deformity, but sometimes a valgus deformity. You will see a clear deformity, especially in the from behind the patient. When you examine the patient actively and passively, he will have a limited range of motion, unsurprisingly. Then when you start to feel he will be tender to touch, you need very carefully to check stability, because with the stability, this will dictate your treatment. So if you plan to do some treatment for this ankle arthritis, stability will be one of the dictation. Will you fuse or replace this ankle? You have to check the subtalar joint, because again, it's another element in the management plan. So with subtalar arthritis, the option to fuse the ankle is not there. You have to try to replace this ankle, because fusing the ankle with an arthritic subtalar means that subtalar arthritis will need fusion very soon, and you end the patient with very stiff segment. So a quick look on the pathoanatomy, which will explain to us about the difference in ankle arthritis than any other arthritis. It's very expected for the ankle, if it's a small joint compared to the knee or the hip, to have an arthritis more commonly, but the surprise is not. The ankle is less arthritic than the knee or hip, and the knee and hip gets more primary arthritis than the ankle. And why? Especially if I told you that the ankle articular cartilage is just 1 mm thickness, while cartilage for the knee is 2 to 3 mm. So imagine more thick cartilage, wider joint space for knee and hip, and still ankle is less commonly to have an arthritis, primary osteoarthritis, than the hip or the knee. The answer will be coming in the biomechanics to understand how the ankle works and how the ankle behaves. So basically, to understand the idea in biomechanics, when you're putting a load in your joints, so for the hip and knee, they load by point loading. Point loading means your load is going on one point at every stage of weight bearing. So if I'm standing now with my knee extended, there is a point where it's a point contact between the medial femoral condyle, mainly the medial femoral condyle and the medial tibial plateau, and a point for the lateral femoral condyle and lateral tibial plateau. And because the medial femoral condyle is going more distal, there is more loading in the medial side than the lateral side, And this explains to you why the medial arthritis in the knee is very common than the lateral arthritis in the knee, lateral compartment arthritis in the knee. So in the hip, you just going, there is the weight-bearing surface of the head, there is a source heel of the acetabulum, and you putting a point loading between the source heel of the acetabulum and the weight-bearing head area of the head. Same in the knee, you have the medial femoral condyle and the medial tibial plateau in the medial compartment, and lateral femoral condyle and lateral tibial plateau in the lateral compartment, and you're putting a point loading on both of them. While in the ankle, it's a surface loading, it's not a point loading. So basically, very confined system of the surface of the tibial plateau, medial mal, and the lateral mal, and it's the talus is just acting and confined inside. Is a very conform joint, and because of the conformity of the joint, the loading is a surface loading. There is no point loading in the ankle. Again, ankle is smaller, ankle cartilage is thinner, and though that ankle is less commonly to have a primary osteoarthritis. And all the time you have to ask yourself why. And the answer for why is, though the knee and hip are more broader, so the larger surface area, thicker cartilage, 2 to 3 mm compared to 1 mm in the ankle, they still getting arthritis, primary arthritis more than the ankle, and that's because of the way of loading. For the hip, you're loading a point loading between the source heel of the acetabulum and the weight-bearing area in the head, and this is the point loading. And that's why this is a common area to collapse with AVN. It's very common to have a central arthritis of the ankle. Of the hip. For the knee, you have the medial femoral condyle prominently more distal, loading on a point at the medial tibial plateau, and lateral femoral condyle loading at a point at the lateral tibial plateau. So point loading medial and lateral. Medial is more prominent. That's why medial compartment arthritis are more commoner than the lateral compartment arthritis in the knee. While in the ankle, there is no point loading. You do a surface loading. So very conformed surface of the tibial plafond, medial mal and lateral mal, and the talus is just sitting inside, very conformed. There is very congruent joint. That's why you do a surface loading rather than a point loading. And from here, you need to understand why post-traumatic arthritis is the most common. Because with every 1 mm movement, you lose 40% of this conformation, and you go from a surface loading to a point loading. And that's why post-traumatic, the ankle is very commonly to get arthritic. So if you compare the primary osteoarthritis, ankle is less common to have a primary osteoarthritis compared to a hip or knee, while post-traumatic, ankle is commoner to have post-traumatic arthritis compared to a hip or knee. So if you have a tibial plateau fracture, your chance to get an arthritis and the time to get the arthritis in is much less than if you have a mal-reduced ankle fracture. So you will get a very early and very commonly post-traumatic ankle arthritis. That is why, because you just lose the surface loading and go to a point loading like what happens in the hip and knee in the normal. I hope this point is clear. So if you come to pathophysiology, so as you see, 80% of ankle arthritis is post-traumatic, and I think you understand now biomechanically why. Idiopathic, not that common, which is the primary osteoarthritis, and again I explained you why. Then it's the other way is to get it an inflammatory arthropathy like the rheumatoid arthritis. So how will we treat an ankle arthritis? In all foot and ankle conditions, we always start with non-operative treatment or conservative treatment. So to help the patient with the walking, you give him a single rocker show, and the rocker show basically has a pump in the bottom, and this pump in the bottom just allows the patient to move from a third to first rocker without stopping at the ankle, so reducing the load over the ankle. You may help the patient with some physiotherapy, pain management, intra-articular injection, especially steroid injection, and they do help the patient a lot. So the second stage, if the patient doesn't respond to this, or if the patient is mainly has a mechanical symptoms, so you can go and do an arthroscopic debridement, because the commonest complaint of this patient, as you see here, is an anterior osteophyte, which is causing anterior impingement, making him difficult to weight bear, making him difficult to do dorsiflexion, to walk up hills or to go upstairs. So you may go and do a chelectomy for this osteophyte. So get this osteophyte debrided arthroscopically, have a look in the joint, do a proper wash of the joint, debride any osteophyte you can see, and this does help the patient as well, but definitely as a temporary measure. If you go to more than this, if the patient has a medial or lateral arthritis, so confined to one place, this is the time you can do a supramalleolar osteotomy just as a joint preservation surgery, like we do in the high tibial osteotomy in the knee. Then the end result, if all this fails, or the patient has an advanced arthritis and there is no way to try any joint preservation, the option will be either to replace or to fuse. So we'll speak about every option in details. So if we start with the commonest option and the most successful option till the moment, which is arthrodesis or fusion, you do a fusion definitely in a young man, especially young women's, with the women's especially because of the way of the bone quality and the way the bone behave. We more toward to replace them. So young man, mostly a manual laborer, so someone who is doing a lot of manual activities, because till the moment we are not so confident in the results of ankle replacement with a high activity or high loading. So if a patient, young, manual worker and with severe arthritis, the option will be for fusion. Definitely if the patient has an infection, there is no point or there is no space for any replacement. Replacement will fail. So if a patient has an infection, you eradicate the infection, give the patient a proper treatment to control the infection, and this is the time you go for a fusion rather than a replacement. Trauma, because with the trauma, the joint will be deformed, so replacing the joint will not be easy. But actually, at the moment, this point is not that valid because we now can do ankle replacement in post-traumatic arthritis, and there is a more variability, more versatility in the ankle replacement implants and options. AVN of the talus, because we all agree that there is no way to put a talar component over an EVN talus, because with necrotic talus, the way for this, the chance for the talar component to collapse and subside is very high. So no one will replace an EVN. As a salvage, if the failed arthroplasty, so arthrodesis remains an option at any time. So if you do an arthroplasty, revise it for infection or something, and you have to go for another revision, so you can salvage this with an arthrodesis. Where you will put your ankle while the arthrodesis? So you have to put the ankle in a neutral dorsiflexion, and this is very, very important. Most of the causes of failed arthrodesis or painful arthrodesis is if you put the foot in plantar flexion. Because when you put the foot when you put the foot in plantar flexion, you're loading a certain point in the ankle, and that's why the fusion always fail and always painful. But when you keep the ankle in neutral dorsiflexion, this means you're loading the whole surface. The chance for healing and fusion is very good, and the problem of pain or problems after that is not that. You need to keep the ankle in 5-degree valgus, which is the natural for it. And you need to keep the ankle in external rotation, because with external rotation, it's easy for you to clear the ground. So if the ankle is just straightforward or internally rotate, this means clearing of the ground during the gait is difficult. So you need to keep the ankle in 5 degrees external rotation, so it will be easy for the patient to clear the ground, clear the foot from the ground without a lot of movement of the hip or knee. So you keep it in neutral dorsiflexion just to load the whole surface of the joint, allow it to unite, fuse, and don't have any problem or pain after that. Number 2, in 5 degrees valgus, because it's the natural alignment of the hind foot, and 5 degrees external rotation to make clearing the foot from the ground during the gait easy without much movement from the hip or the knee. It definitely have its backsides or drawbacks or dark side. And the dark side or complication is bone breakdown, delayed or non-union, and it's about 10%. To be honest, it's very uncommon to have an ankle fusion non-united, especially if you're doing arthroscopic ankle fusion. The risk of failure of fusion or non-union, as any non-union, is high in smokers or in revision cases. Is low. There is not look for continuous trabecular to see if the ankle has been fused. Definitely an infection, malalignment, and the major problem behind the ankle fusion is you fuse a segment which was moving. So rather the patient was having the movement of the ankle and hind foot from 2 joints, which is the ankle and subtalar. You fuse the ankle. This means you load the subtalar more than normal, and as any joint fusion form at anywhere, it always causes an exacerbation of the nerve joint arthritis. So the commonest problem you explain to your patient when you're offering him a fusion is the subtalar arthritis will be exacerbated and will be very, very commonly to happen very quickly. So, and he will need a subtalar fusion at some point very soon. That's why subtalar arthritis is one of the indications to replace rather than to fuse. So again, with the fusion, the main problems you will see in the practice is number one, exacerbation of the subtalar arthritis and need for a subtalar fusion very soon. The second problem, if you put the fusion in the wrong position, especially plantar flexion, patient will have non-union, patient will have a painful fusion. So how we fuse? So we can do this either open or arthroscopic. Both now are valid options. Open we can do from anterior approach, from lateral approach. From anterior approach, we put this anatomical blade. As you can see, from the lateral approach, the good thing, we get the fibula off and we use the fibula as a graft into the joint and we put a lateral plate. We can, with the arthroscopic fusion, we can use a couple of screws, as you can see, either parallel screws or cross screws. And actually, with these compression screws, the fusion happens very rapidly and very safely. Arthroscopic help us in minimal soft tissue dissection. For an open or lateral ankle fusion, you need to open a very big incision, either anterior or lateral. And this is, as we understand, the skin of the distal tibia especially is depending a lot on the perforators coming from the bone. And for a long incision and large dissection of soft tissue, the risk of your wound problems and wound healing problems is very high. That's why we tend toward the arthroscopic fusion rather than the open fusion to save the soft tissue, especially if the soft tissue are already poor or have a poor blood supply or diabetic patient. Number two is the arthroscopic debridement or arthroscopic preparation of the joint. Keep a lot of the stem cells inside without getting them out like an open wound does. So it gives a better chance of healing, a better chance of fusion, and it's definitely quicker procedure and less bleeding. As you can see, the evidence says that both of them will unite in about 12 weeks. Non-union is very low, about 7.5% only. The last form of arthrodesis, when we use it in a salvage procedure, especially in diabetic, or if we're going to fuse the ankle and subtalar, and that's the time we insert a hindfoot nail from the calcaneum up to the talus and up to the tibia, so fusing both the ankle and subtalar joint. And this is commonly used in diabetic patient, in reconstruction patient, in patient with poor bone quality. In patient, we need to fuse both ankle and subtalar, and we don't care about the joint spaces. Other side is ankle replacement, and we understand that as any replacement, we do them definitely to get the patient back to normal function, not like fusion, which will fuse segment of the moving segment of the hind foot. Number two, with the patient, as I told you, have a subtalar arthritis, which means if I fuse his ankle or her ankle, I will end by the subtalar arthritis progressing very, very rapidly. We use it commonly now with the rheumatoid patient, and it does very well. And definitely because we are not confident with the results of ankle replacement at the moment, we keep it only for above 66, low demand, mobile joint, have a good bone stock, have enough stability of the ankle, and we tend more to do the varus ankle rather than the valgus ankle. I'll explain you now why. When not to do a replacement, as any replacement, you cannot do a replacement in a neuropathic joint. You cannot do a replacement with previous history of infection. You cannot do a joint with AVN. You cannot do a joint with ligament laxity or rupture, because honestly, the ankle replacement or whatever replacement is not inherent in itself. And constrained options has its own problems. That's why you have to have a good ankle ligaments before you replace an ankle. Then last one is coronal malalignment, and now we have options for that, but we tend to be away from especially valgus angle, severe valgus angle above 15, because severe valgus ankle above 15 equal that the deltoid ligament is not efficient anymore, and without deltoid efficiency, ankle replacement will fail. So we tend not to replace the ankle if there is coronal malalignment more than 15 degree in valgus. But while in varus, it's easy for us to reconstruct the lateral ligament, but our medial ligament reconstruction is not the greatest. That's why with a severe valgus, deltoid will be attenuated or ruptured, so we don't tend to replace this ankle, but to fuse it. Ankle replacement has passed by a lot of stages. It early has a very bad repetition, saying that ankle replacement not like the knee, not like the hip, but actually because the hip and knee is more commoner, as I explained you at the start, and because they are commoner, they have a lot of development, a lot of implant improvement, a lot of research and experimental work going on. But because the ankle is not commonly to have a primary arthritis, this is not the same for the ankle. It passed by 3 generations. First generation was very highly constrained, as you see on the left side. Because it's highly constrained, there is a lot of stress on the interface. And to understand this point, you need to understand that every joint, and this applies everywhere, not only for the ankle, hip, knee, wherever, shoulder, whatever, you balance between 2 points, stability and loosening. So if you want to get your implant or your joint stable, at the same time, you don't want to be it very stable, because if it's very stable in itself, it put a lot of stress between the implant and bone interface, and this is end by lysis or loosening. So you need to balance between getting your joint or your joint replacement stabilized and stiff compared to getting it loose. If you get the joint highly constrained, means it's very stiff in itself, very stable. This means putting a lot of stress between the stem and the bone, what we call the stem bone interface, and this will end by an early loosening. It was cemented, and it was always have an incongruent poly. It's a very thick poly, taking the shape of the implant and not the congruent. Then we pass to the second stage, which is from this position to another position, when we start using the equality. And equality was a whole poly tibia, so there is no metal component, and it was porous coated, so this wasn't cemented. But the problem is there was very high instance of wear of the poly, and that's why there was a high failure rate and very poor long-term follow-up. Then we move from this stage to stage 3, which is start. We have the mobile bearing, commonly the star. And when we speak about the star, which is the Scandinavian total ankle replacement, it becomes talar component, talar component, tibial component, and a poly in between. And they keep talar and tibial component copper chrome, and they are porous coated, so it's uncemented implant. And they keep a small ridge, as you see here, in the talar component, which makes this poly, although it is mobile bearing, it has some degree of restriction of the bearing. That's why it doesn't dislocate or have any problem. So again, metal component on the tibia side, which is cobalt chrome and has some porous coating, so it's fixed very easily. And again, the same for the talar component. Then a poly in between, which is very conform. There is very conformity. This you can see is very congruent. So the poly is very congruent, not just a box like before. And we keep a small ridge in the talar component. Just doesn't allow this poly to go anywhere. It's just to be mobile bearing, but in single track. This has developed more with the Infinity, which we are using now, which is the commonest implant used, about 60% in UK. And you can see we increased the porous coated. It has small pegs there, and these pegs just stop it in place. So with the small big and big in this configuration, this gives the implant a lot of stability. So porous coated, 3 pegs, and the 3 pegs just insert inside the tibia, keep the implant very stable. Same 2 pegs for the talus. And as you can see, the talus is more curved according to the talar head to resemble the talar head. And as you see, the poly is very congruent with the talar component. And again, there is still a small ridge here, which allow which though it is a mobile bearing, is not fixed bearing, it still moves in one track, doesn't go in or out, and the risk of poly dislocation or poly displacement is very low. So what is the situation at the moment? Where are we? So if you see these 2 studies coming from Rettington, where they are a big arthroplasty unit. So in BJJ 2003 and 2008, they found that the 5-year survivor was about 92%. Yeah, it is not great like the hip or the knee, but 92% is not bad. This 92% went down to 80% after at 10 years point of time, and at 15 years it becomes 76. And they found that the survival of the implant of ankle replacement is better in rheumatoid than osteoarthritis, to 82% compared to 68%. If you have a look on the NGR in 2022, we have done 933 cases all over the UK. The commonest implant used was Infinity, about 60%, and Inbone, about 10%. And the difference between Infinity and Inbone, that the Inbone has a stem in the tibial side, and the talar side is smaller. So Inbone, Infinity, as you have seen in this picture, it's just a Boris coated 3 bigs and Boris coated 2 bigs on the talar side. In the Inbone is exactly the same as the Infinity, but the difference is it has a stem in the tibia and a smaller talar component. Revision rate at 10 years was about 9.9 in males and 10.17 in females. And is the most interesting point is in young age below 66, it's about 12 to 15%, while in above 75 is just 3 to 4% at 10 years. Means 96 to 97% of the implant didn't go for revision after 10 years, which is a very, very good results. If you look at the implant survival, so for every individual implant, you can see that Infinity at 7 years, 96% survival. Inbone at 7 years, 96 survival. Salto at 7 years, 95% survival. So what's the principles if you plan to do an ankle replacement? The most common approach used is the anterior approach. So it's a long incision. You aim to keep your skin detensioned, because again, we're dealing with the distal tibia, and the distal tibia skin depend on the perforators from the bone for its blood supply. So you try to get a very long wound to avoid any tension on the skin edges. Avoid use any retractors, because any self-retaining retractors put a lot of tension on the skin, and this is devoid the skin from its perforator blood supply, and this makes the skin problems much more commoner. You make a thick skin flap to avoid any problem with the vascularity. You minimize the use of retractor, as I explained to you. So the complication from ankle replacement is definitely wound infection, as any replacement. Intra-op fracture, and commonly the intra-op fracture come from the medial mal. This complication is much less now, because we're using now an PSI, or patient-specific instrumentation, which gives us a template to where to cut, and this is gets us away from fracturing the medial mal. Then aseptic loosening on osteolysis. Medial gutter pain, and this is very commonly if you don't clear the medial gutter after you do the replacement. Then fracture of the poly and VTE. So if we compare fusion to total ankle replacement, we're still saying that fusion is the gold standard, but total ankle replacement, as you can see in the previous slides, is doing very well and getting more and more share in the market. So if we speak about comparing fusion to total ankle replacement in ankle arthritis, we cannot ignore the TARVA trial. And TARVA trial is a UK pragmatic trial, have been done multicentric in 2 parallel groups, open label randomized trial. 17 center has joined this trial, and it was 52 weeks follow-up. So it compared both total ankle replacement and ankle fusion, and it compared both of them regarding the functional outcomes and the clinical scores. So it found that both options are valid. Functional results are comparable. Total ankle replacement has some more wound problem than the fusion, and some nerve injury problems, because it's a more bigger wound than the ankle fusion. But on the other side, ankle fusion has more VTE events and non-union, as I explained to you, and sometimes this non-union is asymptomatic in about 70%. It is when they done a prospective control trial. This trial was done in 2009, and it has been published in the Foot and Ankle International. It compared a STAR versus ankle fusion, so before the Infinity in the market and before the Infinity takes this share. So 24 months, they found that ankle treated with the STAR has better function and the nearly equal results regarding the pain relief compared to the fusion. So from TARVA trial and this prospective control trial, we can say that fusion is comparable to replacement, and if each one of them has its merits and challenges, but again and again, ankle replacement is getting better and better, and with implant development, with implant improvement, the ankle replacement results are better and better, and as you can see, the NGR says 96 years survival at 10 years, which is something very, very promising. So we're done with ankle arthritis, and if we start to speak about the ankle instability, so ankle instability, one of the most common sports injury is ankle sprain, and ankle sprain, if it's maltreated or ignored or missed, ankle instability will be the answer. So patient will come to you complaining from giving way. So ankle is not that stable. He doesn't depend on ankle, doesn't trust his ankle to walk. Sometimes it's just painless, and this is commonly with the patient, common with the patient with hypermobility. If it become painful, you need to think about is something injured, especially osteocartilage lesion. Maybe a patient have a peroneal injury or have osteoarthritis from recurrent instability and recurrent injuries. So ankle instability in its nature is painless. If it become painful, think about get an MRI scan. Think about having an osteochondral lesion, peroneal injury, or osteoarthritis. The most important when you examine a patient with ankle instability is to do a Bettino score, and Bettino score to diagnose the hypermobility. I'm sure all of you know it. And if the patient hyperlax, gives us two ideas. Number one, that functional rehab is very, very important and can solve the patient completely. Number two, if I will operate on this patient, I need to consider putting an internal brace rather than just anatomical repair. Because if the patient hyperlax, the ligaments are normally for him hyperlax, and if the ligaments are normally hyperlax, anatomical repair or anatomical reconstruction will not sort his problem. You do your normal examination, have a look at the patient from the back, from the side, from the front. Exclude that the patient has any deformity which is predisposing for ankle instability, like a patient had hindfoot varus. With hindfoot varus, the patient putting a lot of stretch on the lateral structures, so lateral ankle sprain is very expected. Forefoot overpronation, subtle cavus, so any deformity of this makes the ankle unbalanced, putting stress on one side of the ankle rather than the other, and this is the predisposed for ankle sprains and instability. Definitely, you need to do the anterior drawer and varus inversion, anterior drawer to examine the ATFL, and varus inversion to examine the CFL. So types of ankle instability is you need to understand it's not only mechanical. Sometimes it's a functional ankle instability because of loss of proprioceptive sensation, loss of balance, loss of protective reflexes, and anything of this will give the patient a sense of instability, which we call functional instability. Definitely, the commoner is to have a mechanical instability because inefficient ligaments or ligament injury or ligament rupture or whatever. If we speak about the pathoanatomy, we spoke about this before. We'll go quickly through it. So normally your hind foot is in 5 degrees valgus and goes into varus with the inverters. Why is naturally in 5 degree valgus? Because basically your inverters are more stronger than your everters. So the inverters, which is the tip ant and tip post, are normally stronger than the everters, which is peroneus longus and peroneus brevis. That's why your ankle naturally is in 5 degree valgus, because if it's in varus, the inverters will be overpowering while they are already stronger. So your nature, God gives you an ankle in 5 degrees valgus just to balance the overpowering or the stronger tip post and tip ant as an inverter compared to peroneus longus and peroneus brevis as an everter. With cavovirus, we understand definitely that the risk of instability will be high, as I explained to you. When the hind foot is in varus, means a lot of stretch on the lateral structures, means the lateral structure are more prone to have an injury. We have the ankle ligaments is 2 joints. Ankle is not only one joint, it's a syndesmos, which is tibiofibular joint, and then the tibiotalar joint. So with the tibiofibular joint, you have 3 ligaments mainly: the AITFL, BITFL, and the interosseous. AITFL is the most commonly injured, though it is the most strong, but it's most commonly injured because the commonest injury is in external rotation. So if you go to Log-Hansen classification of ankle fractures, you will realize that the ankle fractures commonly happen in external rotation. That's why the 4 types you have: supination, pronation, supination, adduction, supination, external rotation, pronation, abduction, pronation, external rotation. So external rotation in both supination and pronation is the commonest, and because the external rotation is the commonest, the AITFL is the most commonly injured in syndesmosis. Then BITFL is more commonly to be injured in the high sprain. Then we have the interosseous ligament in the syndesmosis itself, and interosseous membrane between the tibia and fibula supporting it. On the lateral side, you have the ATFL. ATFL, which is the anterior tibiofibular ligament, is the most commonly injured ligament in the lateral ankle ligament complex. It's the weakest of them. It's just extending from the anterior colliculus of the lateral malleolus going into the neck of the talus, and it's mainly restrained against inversion, and it works more when the ankle is in plantar flexion. That's why we examine the anterior drawer while ankle is in plantar flexion, and we do anterior drawing. Talar tilt, if this incompetent, so if your anterior tibiofibular ligament is incompetent, this will allow your talus to tilt inside the ankle, not to shift, to tilt. BTFL is very strong, very rare to have an injury. Then CFL, which is restrained mainly against inversion, either in neutral or dorsiflexion, and we examine it by putting the ankle in neutral and trying to invert. Then you have the lateral tibio-calcaneal, and this is deep to the calcaneofibular, and we consider it as part from the calcaneofibular ligament. On the medial side, you have the deltoid ligament. It's a superficial and deep part. Superficial part is 3 parts. It's tibio-navicular, tibio-talar, and tibio-calcaneal. And deep part is just a thickening of the capsule, and it is anterior and posterior tibio-talar. So superficial, 3 parts: tibio-navicular, tibio-talar, tibio-calcaneal, and the deep one, and the superficial is mainly against eversion. And deep part, which is thickening of the capsule, and it's anterior and posterior tibio-talar only, and this is mainly against external rotation. Superficial one is against eversion, deep one is against rotation. On the plantar surface, you have very commonly the plantar fascia, and the most common ligament, which is the spring ligament, the calcaneonavicular ligament, and this goes from the sustentaculum tili, this one, go from the sustentaculum tili of the calcaneum up to the navicular, and the talar head is resting on it. So how you test for ankle instability? The number one is mainly a clinical diagnosis. So if you exclude hyperlaxity by Betten score and you assess the ankle, you see that anterior drawer and varus inversion are positive. So your clinical diagnosis is the most important. Then if you do a stress view, the most commonly stress view is to put the patient weight bearing. And with the patient weight bearing, you can see some talar shift or talar tilt. And definitely you can do a stress view in the form of hanging foot from the table, external rotation stress view. And this will give you a more picture about any injury to the medial structure. Definitely the gold standard is MRI scan. And the MRI scan, we tried after we failed conservative treatment. So once we have a patient with ankle arthritis, sprain or ankle instability, we send for functional rehab, proprioceptive and balance exercise by physio. And if this all fail, we get the patient to MRI scan. How you treat an ankle instability? So with acute injury, just non-operative measures, and they are very successful. So rest the patient in boot, do some physiotherapy with proprioceptive and balance exercises, and muscle strengthening, especially brachii. Then operative treatment, if we plan to operate on that, we operate either by anatomical or non-anatomical repair, and we don't operate on ankle instability very commonly unless the patient fail always, and we exhaust all ways of conservative treatment, or if the patient starts to have problems like OCL or something from the ankle instability. So, and before we do that, we need to ensure that MRI scan showing what ligament is injured, and we plan everything before we go ahead. With chronic injury, definitely there is no space for non-operative treatment, though we try them still, but we know from if it's a chronic injury that commonly we will be going for operative treatment. And operative is either reconstruction, and reconstruction could be anatomical reconstruction, means we get the ligament back to its place using anchors or repair if it's mid-substance injury. Non-anatomical means we get something to do the job of the ligament. We don't repair the ligament. So if we speak about the anatomical repair, the commonest is Prostum gold. And Prostum gold is, Prostum basically got the ATFL and CFL, got them back and inserts a couple of anchors into the distal fibula and pull the ligaments back to their insertion or their footprint. So it is a form of anatomical repair of ATFL and CFL. If the patient is hyperlax, if the ligaments are not that efficient and strong for repair, then we can use an internal brace, which is an artificial ligament done by Arthritis, and this is go in the same plane of the ATFL and do the same job. And sometimes we use it just to support the anatomical repair. So we do an anatomical repair, get an internal brace to support over the anatomical repair. The goal modification of Prostum is he repair the extensor, the inferior extensor retinaculum. And actually with the goal modification, the results of Prostum become much, much better. So the trend or the common practice at the moment is Prostum gold, which is anatomical repair of ATFL and CFL back to their footprint in the fibula. And then both a jacket from outside or support from outside or seat belt from outside in the form of internal brace. Definitely, we can do this open and arthroscopic, but arthroscopic is very fancy, so it's not that common practice. The commonest practice is to have it anatomically. This is anatomical repair. As you can see, this is Prostum gold. So we bolt the ligaments back to their foot insertion using two couple of anchors. Then non-anatomical, you have two options. The option number one is Evans. As you can see, Evans, we cut the peroneus brevis, bolt it through a tunnel in the distal fibula and just hold it in the back. So the distal part of the peroneus brevis is doing the job of ATFL. On the other side, we have the Christmas knock. And with the Christmas knock, we just split the peroneus brevis into two and take the anterior part, pass it through a tunnel in the fibula and hold it on the posterior part. And by this way, we keep the action of the peroneus brevis working and use the anterior slit from the peroneus brevis as ATFL. So this is the heel instability, this ankle instability. If you come to the third common topic and the third, one of the most common presentation of patient to the foot and ankle clinic is heel pain. And heel pain, as you can see, has a lot of differential diagnosis. So if you have a heel pain, you may have a calcaneal spare, and calcaneal spare can be blunter or can be posterior. And a spare basically because there is a lot of micro injury at the insertion of the fascia or the ligament. And with the micro injuries, there is a lot of inflammation, and this inflammation recruits calcium to come and predispose here, and this is why the spare formed. You may have a fat pad atrophy. You understand that you are not walking on your heel directly, but you have some fat pad here, and this fat pad can be atrophied, and if it is atrophied, there is more contact between the calcaneum and the ground, and this is where the pain is. You may have Achilles tendinopathy, and Achilles tendinopathy could be insertional at the site of the insertion or could be non-insertional. And you may have a calcaneal stress fracture, and it's common in people with steroids, common in people during puberty, common in females, in osteoporotic females, common in people who are doing a lot of activities, especially if they are stressing the calcaneum. Then you may have a Hagelin deformity, and this is a Hagelin deformity. It's a bony prominence here, and this bony prominence causing this tendon to wrap against it and cause a very commonly insertional ankle tendinopathy, Achilles tendinopathy, which may end by rupturing of the Achilles. Then you may have a posterior ankle impingement, means you have an osteophyte here. That's why the ankle is posteriorly impinging, and this is cause give the patient a heel pain. These three in bold, they are the uncommon causes of heel pain, but they are still happen and they always missed. Baxter nerve entrapment, jogger's foot, sphere's foot, and plantar fasciitis. If we come to the Baxter nerve entrapment, so Baxter is the first branch of the lateral plantar nerve. So this is the lateral plantar nerve. It gives one branch to go back here, and this branch is the Baxter nerve. And this is basically innervating the abductor digiti minimi. In the runner and athletes, they get compressed here, between the abductor hallucis longus and the medial side of quadratus planti. So where he putting his thumb, this is between the abductor hallucis longus and the medial side of quadratus planti, and this is where the Baxter nerve, which is a dorsal branch from the lateral plantar nerve, get compressed. Patient will have heel pain, and this will need us to go and release the abductor hallucis longus. Jogger's foot, and basically Baxter nerve entrapment was the lateral plantar nerve. Jogger's foot is the medial plantar nerve, and it's always compressed at what we call knot of Henry. Here, where the FDL and FHL just go across each other, this is a common site to compress the medial plantar nerve and gives you what's called jogger's foot. And the main treatment for this is to release the compression by foot orthosis, and if it doesn't help, to go and release the knot of Henry. Severe disease, and a lot of you see this in skeletally immature. As you can see, it's a lot of fragmentation of the posterior tuberosity, or what we call the apophysis. So I'm sure all of you understand that epiphysis is end of the bone, and apophysis is where the tendon or ligament attaches. So here, where is the Achilles attaches? This is the calcaneal apophysis, and it's common to have apophysitis in the skeletally immature, especially the very active children doing football, a lot of repetitive microtrauma. They get their apophysis, calcaneal apophysis, fragmented, as you can see, and they are a lot of pain, and this pain always settles when they are 18 or plus. And if you have any doubt about it, get an MRI scan to exclude any underlying problem, especially stress fracture. And the treatment is very conservative, so just rest, heal bad. If you need some casting, and in very, very rare situation, you may need to stretch in the Achilles. Plantar fasciitis, the commonest and the most worst complaint you will see in foot and ankle clinic. So when you are a foot and ankle surgeon, your worst time when you have a patient coming in saying, I have a plantar fasciitis. Though it is very, very simple pathology, but unfortunately very resistant to treat. And patient, you'll be surprised if I told you that plantar fasciitis is self-limiting. Means if the patient leave it alone, it will settle at one day. But when? This is a difficult question. So plantar fasciitis or dancer heel. So it's called dancer heel because there is a stretch on the plantar fascia in the dancers. And as I told you, the surprise is the plantar fasciitis is a self-limiting problem, but the problem is irritating the patient all the time, painful. Patient cannot walk normally, and patient is keen to try different modalities of treatment, and it is very resistant. And you may try every treatment, and sometimes it never responds. Patient will come with old age, commonly heel bad stiffness and plantar fascia thickening. The common occupation is the patient who's standing for long hours, people working in airports, teachers, the people, cashiers, the people who are on feet all of the day. It's commonly to be a start-up heel pain, and very common, you remember that very common complaint of the first few steps in the morning are very, very difficult, and once I start walking, it's okay. And this is basically because overnight, when you're relaxing, your foot is like that. When you're sleeping, your foot at the end of the day, just relaxing in plantar flexion. So the plantar fascia is relaxed. With the first step in the morning, you stretch the plantar fascia, and that's why the start-up pain in the morning is very common. Once the patient starts to walk, the plantar fascia starts to be stretched, the pain is less and less. That's why pain is very commonly in the morning. When you examine, because the patient is in pain in the heel, the patient will avoid to do a heel strike. And added to that, Achilles is always tight because the patient doesn't do complete dorsiflexion. If you feel some tenderness over the plantar fascia, especially at near the insertion, and if you test for the Achilles tendon, you'll find that the Achilles is tight, either from the gastroc or from the Achilles itself, and this is differentiated by Sever's coil test. But because you understand that the fascia is underneath the foot and then attached to the tuberosity and going in continuously with the Achilles, when the Achilles is tight, the plantar fascia is under stretch. And to be honest, from my own practice, releasing the gastroc is very, very helpful to the patient who has tried all non-operative treatment and hasn't responded. So, bit of anatomy, you understand that it's the plantar fascia originating from here, not inserting. Be careful. Originating from the medial calcaneal tuberosity in continuity with the Achilles, and then it goes into central band, lateral band, and medial band. And central band goes into the three toes, medial band to the middle to the little toe, and then lateral band to the little toe, and medial band to the hallux. The function mainly, as you understand, is to create the medial longitudinal arch and to do the windlass effect. So, with repetitive trauma, commonly at the insertion site, this insertion site start to have a micro trauma. With micro trauma, healing, inflammation, and this gets area inflamed and painful, and that's what recruits sometimes calcium and causes the calcaneal spur. You diagnose it mainly clinically, and you will never miss a patient with plantar fasciitis, and he will never miss you. And other than this, you can do an ultrasound to see if there's any thickening in the plantar fascia, and definitely MRI scan is a modality of investigation. Treatment, very painful for the surgeon. You send the patient for all forms of treatment, and they always come back to say, oh, I didn't get any improvement. So starting from show modification, have some heel pads underneath, try to avoid long standing, a lot of options of injection, steroid injection, which is very risky to rupture the plantar fascia, but sometimes they help if one injection. Extracorporeal shockwave, PRP injection, all these options, and you have to try all of them once or twice and for a good time before you commit to a surgery, because surgery doesn't have a consistent results. So results are not consistent. Some people get very good help from the release or the lengthening of Achilles. Some people doesn't go any treatment or any improvement. So I've seen patients which come in severus coil positive, Achilles is tight, and they ask for gastric release, though the pathology say no. And with gastric release, they are very happy, and plantar fasciitis is very, very better, much better. On the other hand, people who have very clear indication, good indication, we do release of the gastric or lengthening of the Achilles with a strier or whatever procedure, and they still in a lot of pain and doesn't get any improvement. So plantar fascia, one of the headaches of foot and ankle practice. End of the corridor is a surgical treatment if all non-operative fails, and surgical treatment, as I explained you, will be either a proximal gastric release or lengthening of the Achilles, or on the other side, if you want, just to debride or even to release the plantar fascia. Commonest condition in all exams, in all foot and ankle clinics, in all vivas, in all orals is Hallux Valgus. And your foot and ankle question in the FRCS in Part A will be mainly Hallux Valgus, and in Part B, Hallux Valgus and flat foot are very, very common to come in the exam. So the Hallux Valgus patient here will come to you to complain mainly either from the bunion itself. So this bunion will be inflamed, hot, red, tender, and difficult to put a shoes on. Or he will come to complain from transfer metatarsalgia. So to understand the transfer metatarsalgia, normally you put first weight on the ball of the first toe or head of the first metatarsal, then it goes across to the fifth. So normally what hits the ground first and what takes the weight first is the first metatarsal head. And if this first metatarsal head not in place, dorsiflexed because of or defunctioned because of the Hallux Valgus, the patient put more weight on the second, third, and fourth, and this is called transfer metatarsalgia, means because weight has been transferred from where it naturally is, which is the first metatarsal, to second, third, and fourth, which is not naturally loaded. This when the metatarsalgia or pain under the metatarsal heads happen. So patient will come to complain either from the bunion itself, hot, red, tender, swollen, or he may come to complain from transfer metatarsalgia. And this because normally, again, when you put your foot in the ground, first thing to get the weight is the first metatarsal head, and then the arcade after that gets some weight, but the main weight goes to the first metatarsal head. If first metatarsal head not in place because of the Hallux Valgus, this means all the weight will go to the second, third, and fourth or lesser toes, and this is when the transfer metatarsalgia happens. They may come, as you see in this picture, with deformity of the lesser toes secondary to the hallux valgus, which is commonly the hammer toe. And to understand why the hammer toe happen with the hallux valgus, basically, if you can see, now this is, you can see here, the hallux valgus happens. Once the hallux valgus happens, this is now rotated into pronation. So the sesamoids are displaced. They are not putting weight, they are not getting weight anymore. And this ends by putting a lot of stress here. And because the hallux valgus deformity doesn't give any space for the second toe, the second toe reflexively get into extension or hyperextension at the MTB joint. And with the long-standing hyperextension here, the plantar plates start to attenuate. And once it's attenuated, the joint, the toe go in this hammer position. Again, hallux valgus, first metatarsal head is dorsiflexed, is not touching the ground. Transfer metatarsalgia. With the hallux valgus pronation, the sesamoids are displaced. And because they are displaced, they don't get normal weight. And from that, all the weight is going onto the lesser toes. With the hallux valgus deformity, there is no space for the second toe. So second toe is continuously elevated. And because it's elevated, this attenuate the plantar plate and end by hammering toe or a fixed dorsiflexed toe or extended toe. When you look for a patient with hallux valgus, very, very important to have a look in the shoes, and you will see the shoes resembling the same shape of the foot. So their shoes will be having a bump here, and there is a bit pointed toe box from the front. There will be prominence, as you can see, either here in the hallux valgus, the bunion, or underneath the metatarsal heads. You will have some pronation of the big toe, as you can see. So this big toe is not straight. If you look to the nail plane compared to this nail plane, this is pronated. This nail should be parallel to this nail, but actually this is pronated. Overcrowded lesser toes, as you see, callosis under the metatarsal heads because of transfer metatarsalgia, as we explained. So how you examine? So you have to see the patient again, same protocol. Patient is standing, walking, then from the back, then from the side, then from the front. So when you have look at the gait, so very commonly to have associated flat foot with hallux valgus. If you feel patient was standing, firstly with the patient standing, you can see hallux heel valgus, too many toe sign, collapsed arch, and definitely you can spot the hallux valgus deformity and the lesser toes deformity on looking from the front. When you put your hand on, there is tenderness over the bunion itself, and when you start to move the joint, maybe the joint painful because of associated some MTB arthritis, or maybe not painful. You have to assess if this is hallux valgus is correctable or not, because this gives you two ideas. Idea number one, will you need to do a soft tissue release in the operation or not, and give you an idea if the joint is still congruent or not. You have to test for the TMT joint, its mobility and movement. If it's painful, means it's the first TMT joint is arthritic. If it's hypermobile, so means in both situations that you need to do something for the first TMT joint to address the hallux valgus. You cannot address the hallux valgus from distal, either by osteotomy or fusion, while the TMT joint is hypermobile or arthritic. Then the test you do is a grinding test you see in this picture. So basically you push in and you start rotating the toe, and this gives you an idea if there is an arthritis in the MTB joint or not. And this will answer one of the questions about the treatment, saying if you have an arthritis here, there is no point to do osteotomy. So you can correct the hallux valgus and the hallux rigidus, which is arthritis in the first MTB, by fusing the first MTB joint. Very important to test for tendo Achilles, ensure if it's tight or not, because if it's tight and cervical squat is positive, with the Achilles tight, you overload the forefoot, and this is add to the problem we explained about hammer toe and transfer metatarsalgia. Definitely the neurovascular situation and Betten score. Etiology, so there is no fixed point of etiology. We know that there is some inheritance background. Is very common to run in families, especially in female. So it's very common for females to have it inherited from mom or aunt or grandmom. And Other than this, there's a lot of factors, environmental factors, which add to the inherited factor in developing the hallux valgus. So, like a high heel shoes, if you're using a high heel, you're putting the foot in this position already, and forefoot overloading, as we told about flat foot, ligament laxity, and rheumatoid. If you come to muscle anatomy to understand, so the situation start with a medial attenuation, medial capsule attenuation. With the medial capsule attenuation, the phalanx deviates laterally, and because the phalanx deviates laterally, this moves the whole thing, as you can see, move the whole thing away from the sesamoid, rather than the sesamoid was centered in the sesamoid joints or the sesamoid foci, is away from the sesamoid, and this moves all the muscles on this side to this to more varus, and this is disturb the whole mechanics around the toe. So medial capsule attenuation, this end by the hallux deviating into laterally. Metatarsal head displays medially against the hallux. If you imagine, this is the hallux valgus. So if the phalanx is going laterally, this means the head is coming medially. Phalanx is going lateral, head is coming medial, and with phalanx going lateral because of attenuation of this medial capsule, this will take the sesamoid with it. So the sesamoid is attached to the flexor hallucis brevis, and this will take the sesamoid away. So the loading mechanism of the hallux is become abnormal, and this causes imbalance between the muscles around the hallux. So once that's done, the adductor tendon, rather than being adductor, become, because it displaces, it become an abductor force. So it's adding to the hallux valgus deformity rather than correcting it. Everything will deviate. So lateral deviation of EFHL and FHL, and this makes them more valgus deforming force rather than just extending or flexing force. Medial attenuation of the capsule, the phalanx goes laterally, the head comes medially. With the phalanx going laterally, it pulls the sesamoid with them because it's attached to the FHP. With the sesamoid moving this way, all the muscle around the hallux become imbalanced. So the adductor become abductor. AHL and AFHL are going rather than being extending and flexing, because the phalanx is going lateral. It will be more of a deforming force. It's causing more valgus. This ended by prominence of the medial side by the medially deviated metatarsal head. This is when the bunion corrects. So we diagnose it with weight-bearing X-ray. We have to draw some lines and see some angles. The most important for us is the hallux valgus angle, which is between the longitudinal axis of the B1 or of the proximal phalanx and longitudinal axis of the metatarsal, and this should be normally below 15 degrees, 16 degree. Then you have the intermetatarsal angle, so between the longitudinal axis of the second, longitudinal axis of the first, which should be within 10 degrees. Then the DMMA, which is the distal metatarsal articular angle. You draw a line, this is the longitudinal axis. You draw a line perpendicular on the articular surface, and parallel to the articular surface, and the perpendicular on it, and this is the angle which is the DMMA, and again we don't accept beyond 10. Then the interphalangeus angle, if you draw a line along the longitudinal axis of the distal phalanx, a line along the longitudinal axis of proximal phalanx, this is what we call the interphalangeus or interphalangeal angle. Based on these angles, you will decide your treatment. So if your problem is in the intermetatarsal angle, meaning the intermetatarsal angle is open, so either you need to do a proximal osteotomy or a proximal fusion. If your intermetatarsal angle is reasonable, but the hallux valgus angle is big, this is the time you can think about either scarf osteotomy or chevron osteotomy. Then if you come to a severe hallux valgus deformity, severe increased intermetatarsal angle, you need to think about double osteotomy. So you may do something distal and something proximal. The goal of treatment of hallux valgus, we are not plastic surgeon. We don't correct deformities. So if hallux valgus is not painful, is not affecting the normal day life of the patient, we don't operate. Our aim is to realign the first ray, get the first ray functioning again, no transfer metatarsalgia, and to correct the deformity and to relieve the bunion pain if the patient has. We can do this to start with non-operative treatment. So patient to modify the shoes, make the shoes white 2 box, try to avoid long standing, try to use some arch support orthotics, and some toe separator just to separate between the toes and push the hallux back in normal. If this is do help, that's absolutely fine. If this doesn't help, so we have to go and correct. And when we correct, we need, as I told you, while we examining, we have test if the hallux valgus is correctable or not. And this is to answer this question: will we do a McBride or soft tissue procedure or not? So if the hallux valgus is correctable, means the soft tissue needs to be released to get this correction done. If it's not correctable, so there's no point. So McBride, basically, modified McBride, basically, we release all the lateral structure, including the lateral capsule, the abductor hallucis, and this is allow the toe to correct. So we go and get we release all the lateral structure, allow the joint, allow the toe to correct, and by the end of the operation, we do the modification, which is plication of the medial capsule, which is maintaining this in correct position. So McBride advises to go and release the lateral structure, including the abductor hallucis and the adductor hallucis and the capsule. And the modified one is to repair and do ligation or tightening of the capsule on the medial side. Then the types of operation, very simply, all hallux valgus can be corrected from scarf osteotomy except if there is first TMT abnormality. All hallux valgus can be corrected by scarf osteotomy except if there is TMT arthritis or TMT hypermobility. I will explain to you why scarf now. So first and the commonest distal metatarsal osteotomy is chevron. And as you can see, chevron, we make a V shape. This is the metatarsal, we make a V shape. This limb should be a bit longer than this to avoid the blood supply here. And then we just shift the head laterally and the shaft medially. And just, it is very, very inherently stable, or we can stick a screw in. What the chevron does, it just correct the translation. So as we agreed, phalanx is going laterally, head is coming medially. So all the chevron does is just move the head back to lateral and the shaft to medial, and that's it. So it doesn't correct the lens, it doesn't correct the plantar and dorsiflexion, it only corrects the translation. On the other hand, Aiken osteotomy is just a distal closing wedge osteotomy, lateral closing wedge, medial closing wedge osteotomy of Aiken, of the phalanx. So with Aiken osteotomy, you cut here in the metaphyseal area of the phalanx, and you remove a wedge and you close the wedge medially. So you correct the interphalangeus angle. Scarf, which is a golden standard for treating all hallux valgus, it gives you a very versatile results. You can correct the translation as a chevron, you can correct plantar and dorsiflexion, you can correct rotation, you can correct whatever you want. Basically, what you do a step cut like that. This is distal and a transverse limb and a proximal limb. And once you do that, you have the option. So imagine with me, this is the metatarsal. I'm cutting here distal, going a transverse limb, and here proximal. If my cut is this way, means that when I move, the head will go back, means I will shorten the metatarsal. If my cut is this way, distally, this means when I move the head, it comes more prominent, I lengthen the metatarsal. The transverse cut, if I do it parallel to the first ray or the first metatarsal, it will not do any plantarization or dorsiflexing. It just move it. But imagine if I do the cut like that, what will happen? When I move, it just slips down, so it plantarizes the first metatarsal, and other way around. If I go this way, start to move, so this slips the metatarsal over the head, so it makes it more dorsiflexive. Again, distal cut, transverse limb, and proximal cut. If distal cut, this is the metatarsal. If distal cut is this way, means when I move the head, I'm moving the head from medial to lateral, means I'm lengthening the metatarsal. Other way around, if it's this way, and I'm moving the head, I'm shortening the metatarsal. The plane I cut the transverse limb, if it's just parallel to the metatarsal, perpendicular to the metatarsal, there's just translation. There is no movement up and down. Imagine if I make my hand like that, and start to move this way and the shaft other way. So I'm just plantarizing. And if I do that, I'm dorsiflexing. To understand this well, there's no way until you try it yourself. Get a carrot from the kitchen and do a cut on the carrot and try to do the cut straight. Try to do the cut this way, distally, or this way, and see will it lengthen or not. And try to do the cut, the transverse cut, perpendicular, dorsiflexing, or plantar flexing. If this doesn't help, or if the first TMT has any problem, so it's more to do with fusion of the first TMT. The good thing about the fusion of TMT or Lapidus procedure is it's a proximal correction, so the power of correction is very, very high compared to the distal correction. If you have any degeneration in the hallux, it becomes a hallux rigidus, which means degenerated first MTB joint. The options you have either to fuse it, which is very, very commonly used in the gold standard, or to do a killer resection, means you get part of the distal phalanx removed and stick a wire in and you keep the toe floating and you just do an excision after blasting. Or to replace it, and we have a stylistic implant, and we have before Capitiva, and we have now stylistic implant, which are doing very, very well. What if you have a rheumatoid patient with Hallux Valgus? So with the rheumatoid patient, poor bone quality, poor soft tissue quality, there is no room for realignment or osteotomy. So you always go for fusion of MTB and Stein's Bay of the acertomes. The complication we may have with the osteotomy of the Hallux Valgus is troughing. And to understand the troughing, if you cut in a cortical bone, there is no way to trough. While if you cut in a cancellous bone, as you can see in this picture, once you move the two parts of the osteotomy, you can have this limb sunking into the medulla. And this means your cut is very deep. You have to have your cut very superficial. So it is in cortical bone, not in cancellous bone, to avoid any troughing. Risk of fracturing, especially if you put your screw. Risk of hallux valgus, which is a big problem. And this is happening if we do an overcorrection. Second transfer metatarsalgia, if I don't correct the plantar flexion as I explained. Painful neuromas, especially if you injure the nerve, the dorsomedial branch of saphenous. Avascular necrosis of the head, if you attack the area of blood supply, which is just plantar to the apex. Recurrence, especially if the patient has an hyperlaxity, and cock-up deformity, as you can see, if you do a killer or you do any injury to the FHL, this will end by what we call a cock-up toe. Hallux valgus is commonly to be a complication of Hallux valgus correction. It's rare to see it idiopathically. It's more commonly to be post-surgery. And to be honest, it's one of the major problems the patient may have after overcorrection of Hallux valgus, and very devastating because with the Hallux virus, it's so difficult for you. If you have a look on this foot, it's so difficult for you to put it in a shoes. So Hallux virus is one of the most difficult complications and most irritating to the patient, and which needs a correction or revision. The main problem is difficult in wearing the shoes. If you have pain, this indicates that the joint become arthritic. If you can see, it's mostly commonly post Hallux valgus surgery. If you do an overcorrection, if you do an excessive release or excessive tightening of the medial. So either you do excessive release laterally, excessive tightening medially, or you do a resection of the abductor hallucis. Any of this will get the toe into Hallux virus, and as I told you, it's one of the major complications. Thank you so much. So a long lecture, I know, but yeah, Hallux valgus is very, very important, very common to come in the exams. That's why I was keen to cover it as much as I can. Scarf, don't depend on any explanation. You have to go get a carrot and try it on the carrot to understand what's plantarizing, what are dorsiflexing, what's shortening, what's lengthening. So have a look on the Google. You can see the shape of the cut or the step cut, and from this step cut you can get an idea how to do. But practicing on a carrot is, to be honest with you, a scarf one of the most difficult operations to do, and you don't do it unless you are very senior, because if mistakes happens, it's a big problem. And you need to understand the mechanics. You need to understand where to cut. how to shorten, how to long, how to lengthen, how to do plantarizing, how to do dorsiflexing. So a scarf, try to practice on a carrot before you practice on the patient. It's not an easy operation. To myself and to my understanding, it's one of the most challenging, one of the most stepping learning curve, which needs more time. From a lot of the seniors I've been trained with, don't commit to do a scarf before you do at least 100. 100 will be a lot of mistakes, but yeah, can be accommodated before you can say I do scarf. To say I do scarf, you need to do at least 100. I hope it was useful. A bit lengthy lecture, but I'm very sorry for that. I couldn't make it any shorter. I want to give you as much as I can from foot and ankle before you go for the exam next month. Please put your feedbacks when you receive it. So Mid-All will be sending you feedbacks if he didn't. And put your feedback. All the points you put is very useful, very important to me, and help me improving in the next sessions. I will see you next Friday with lecture number 5. And I hope by this time I'll have all your feedback. And I promise you I'll put all the points you put in the feedback into action. You'll receive your attendance certificate as usual after you send the feedback. And I hope you all a very good evening. And if there's any question, I'm more than happy to answer.
There isn't any questions in the box now.
Perfect. I hope this is because the lecture was clear.
It was clear. It was very clear.
Okay, that's really good. Okay.
Thank you.
Yeah, I'll not take more from your time. It's nearly 10:30. So enjoy it, put your feedback, and have a good evening. And see you all next Friday.
Thank you very much. Thank you. Thanks for your time. Thanks everyone for attending.